Dr. Martin Rutherford, certified functional medicine practitioner, chiropractor since 1979.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
Every week we do a new presentation on some aspect of ultimately chronic pain. We do chronic pain. I can't even say. I've been doing it for a long time, long before it became a popular topic in the news as it's been in the last year or so. This week we're going to do fibromyalgia, and interestingly enough, one of the things that we have done is meld two disciplines of functional medicine and functional neurology to address chronic pain. And over the period of time, we have played with the balance of functional medicine and functional neurology and how we should apply it to each individual case. And it's been interesting, functional medicine practitioner first, working with people with diet and working with people with herbs and botanicals and things of that nature. And ultimately having Dr. Gates come into the practice and applying his discipline's principles very proficiently, I might add, relative to the brain. And as time went on, it was a little bit of a battle. I don't know if it was called a battle. We were kind of agreeing on it, but we used to do, some people we would pick out and just do what you might call the nutritional aspects. We would call the metabolic and the diet, the herbs, the botanicals. We would try to address maybe stress mechanisms with adaptocrines, which are herbs for the brain and adrenal glands and stuff like that. And then some patients we would just do the brain, dizziness, vertigo. And as time came on, we started to see that it was more efficient and way more effective to do both at the same time. Ultimately, I started to realize, the functional neurologist already knew this, that pretty much most chronic pain is felt in the brain, is perceived in the brain, and it is brain function to which all of these medications are directed. The antidepressants, the antihypertensive, well, not all the antihypertensives, but Cymbalta and Savell and all these types of things. Anyway, we started having a saying around here, all chronic pain is really in the brain. And even though you can help with diet, really you have to affect changes in the brain itself to be able to reverse and actually get these chronic problems under control. It's still kind of a controversial idea. I don't know why all the drugs are pointed at doing that. All the pain drugs are pointed at doing that. But in the alternative world, I think it's easier, and that's not even easy, but it's easier to do like the herbs, the botanicals, the gut, the leaky guts, the small intestinal bacterial overgrowths and that. And I say all that to say, today we have an interesting chronic pain situation in which we're going to talk about fibromyalgia. And just to certify, and that's not the word I'm using, I'm looking for, what we were just talking about, new literature on associations of fibromyalgia and decreased gray matter in the brain. And if you go back through many of our presentations, you're going to find if we talk about central pain syndrome, we're going to talk about the brain. Talk about fibromyalgia, we're going to talk about the brain. Dizziness, vertigo, balance, irritable bowel syndrome, chronic fatigue, we're going to talk about the brain. And I think that's why we get maybe a more consistently successful result than at least we used to get by separating them or doing one or the other or so on and so forth. So this is a topic that just again plays right into what we perceive and what we see in our daily activities here and our daily clinical trials, if you will, of treating patients. So this is interesting and a little disturbing to me, in as much as I've been diagnosed with fibromyalgia. It's under control. But we're going to talk about how fibromyalgia and chronic pain and its effects on physiology decrease gray matter in the brain. So fibromyalgia.
Okay.
used to be thought of as muscle pain. I am now seeing commercials on television that sells Lyrica that does say it's nerve pain.
Oh, that's good.
I
That's
just
good. They
saw
must
it
be
just the
watching
other day.
our broadcast.
I thought that just the other day. I saw that, and they have a lot of little, like representations of pain all over the person saying that it's actually nerve pain. First time I've ever seen that. And it is.
We always say that because we were one of the first people online to really be talking about the association with fibromyalgia and small fiber peripheral neuropathy. We did a broadcast. There's no silver bullet, I think, for fibromyalgia. It's a nerve problem. It's not a muscle problem. So that's kind of interesting. But going through fibromyalgia, it's a multifactorial problem. Hopefully, as many of you know, if that's a new concept to you, go back on powerhealthtalk.com, search fibromyalgia. We've done lots of videos on it, and we've talked about all of the individual components, which consist of really the reasons why you have pain. And it may be something or a combination thereof of autoimmune thyroid disease, where your immune system is killing your thyroid. That's been associated with fibromyalgia. To childhood trauma, talking specifically about abuse, ranging to gastrointestinal dysfunction, to gluten intolerances, irritable bowel syndrome, ranging to poor sleep patterns, which we're going to highlight a little bit today, and how that can affect your body and your brain's ability to shut off pain coming down through the spinal cord, as well as the now infamous small fiber peripheral neuropathy, which is where the pain nerves actually start to die and degenerate, and upwards of half of fibromyalgia patients have now been shown to have this. So those are the multifactorial aspects of fibromyalgia. Yes, there are others, but those are the main points that we usually like to hit on. And we also have to understand with each of those kind of peripheral manifestations, so to speak, your immune system's killing your thyroid, you have gastrointestinal inflammation, you may have small fiber neuropathy. But with all of that being known, what they see across the board in fibromyalgia patients is this change in the brain to where parts of the brain are not sensing sensation correctly. They're not interpreting these signals like normal people who don't have fibromyalgia, how they would interpret them. And then now what we're talking about today is really how gray matter in the brain is being shown to be reduced, which is very, very, very interesting for the fibromyalgia sufferer. And just so you know, those who can have remission of their pain, it's now being shown that for chronic pain patients whose pain goes away, these areas of decreased gray matter can actually come back to normal.
Yes.
Yeah. So that's attached to today's podcast.
And I think mine is actually.
You have to access it through powerhealthtalk.com to get all the research articles that we attach each week, but we do have that attached.
Yeah, I'm way better.
Mm-hmm. Yeah,
really,
you are way better.
I am way better than what we
much better. So in terms of the current literature, I was going to bring a brain model up, but a lot of people listen to us through podcasts, so we'll just kind of have to visualize, so to speak, as to what is going on in the brain. Now, there are many different parts of your brain. The front part is the frontal lobe. The back of your head is where you see things. It's called the occipital lobe. Right behind the frontal lobe, if you kind of take where your ears are at and go to the other ear, drawing a line over the top of your head, right behind there, I'm approximating just so you know, is an area called the parietal lobe. That's where we feel things. And then deep in the center is what they term the parasagittal region. So it's called the cingulate area. You don't need to remember that, but just know the middle part of your brain, if you were looking at a mirror and you were to cut your brain in half, right and left side.
Looks like a mohawk.
Yeah.
Seriously.
Yeah, exactly.
It looks like, if you picture like a mohawk on top of your head, and then it just goes down and slices your head in two, the part that's the mohawk is where he's talking about.
Exactly. So that part of your brain, termed the cingulate area, is what's been shown definitively from research study to research study to be abnormal in fibromyalgia sufferers. And even though different MRI studies may say, well, this part of the brain is smaller, and another MRI study may say, well, no, this part of the brain is smaller, pretty much uniformly they agree that this area that Dr. Rutherford alluded to as the mohawk area is atrophied in patients who have fibromyalgia for a long period of time.
Atrophy gets smaller.
It gets smaller.
I know all of you knew that.
Now, you won't necessarily see that on a standard MRI. So a lot of you are going to scream at the TV right now saying, my MRI was normal. Now, these are more sophisticated types of MRI machines and MRI studies that are used in research. So they have enhanced capability to really quantify the density of brain cells in different areas of the brain, whereas your standard MRI is really looking for a tumor or a stroke. So that's an important point to really understand. And they're seeing these variations in density in gray matter and a number of different conditions, highlighting what Dr. Rutherford was saying, where most of these chronic pain, really if you think of chronic conditions, so to speak, that have a neurological component, they have changes in gray matter density as well. So for example, we're finding that OCD patients have differing gray matters than people who don't have OCD versus schizophrenics. And relatives of schizophrenics have differing gray matter densities comparing both of those groups. And then it's even been seen in kids who have conduct disorders. So the kid who just repeatedly gets into trouble and doesn't seem to understand why they're, constantly on timeout, they have gray matter densities that are different too. So just know that if you have fibromyalgia, it's not like this is the only condition where we're seeing this, but it is important to each condition. It's very important to fibromyalgia patients. Now, they've also done studies comparing young individuals with fibromyalgia versus old individuals with fibromyalgia. And they see that if you're a younger individual with fibromyalgia, pretty much the same areas where they see decreased density develop in the latter years, actually they have increased density early on, which is kind of cool. So the same area that may be atrophied, so to speak, in a fibromyalgia sufferer who's had it for 30 years, take that individual 30 years before, probably they would have had increased density in that area. So going back and asking, well, why would that be? We have to look at the overall clinical picture of fibromyalgia and kind of what I alluded to in the overview. There are a lot of things wrong with the fibro sufferer. So you may have small fiber neuropathy. In essence, we know that there are too many pain signals, that are coming into the brain all at once. So that can lead to an area becoming inundated, so to speak, with all these pain signals. And so that can cause maybe the brain cells to take on just a little too much water, a little too much metabolites. And then through time, these areas of the brain are thought to kind of burn themselves out, so to speak. And that's why they're losing density. And in actuality, going further into the literature, were you going to interject something?
So one of the main tenets here and in neurology of fibromyalgia is that the fibromyalgia sufferer's brain starts to lose the ability to filter out pain. Mm-hmm. Is that the same as their brain area burning out? And then ultimately there are parts of the brain that start to learn the pain. Is that related
basically
to this?
In the literature, they're just saying, we have researchers saying these areas of the brain are shrunk in older individuals with fibromyalgia, younger individuals, they're swollen, they're bigger. They're not extrapolating too much. Okay. And as I put into the description of today's broadcast, I was going to insert our clinical understanding as well as our observations of the condition.
I'm in a very simplistic observatory position here. The patient comes in, the vast majority of them get better, and I'm assuming that their brain starts working properly again.
And that's what they've shown. They've shown that basically chronic pain patients who then have not had pain for 12 months, these alterations in gray matter restore themselves to normal.
Okay.
So it probably is an element.
Probably has to do with it.
It does. And I think it probably is an element of you're inundated with so many pain signals that these areas of the brain first get kind of overstimulated, and then through time that's not good neurologically, and then that can lead to areas of the brain losing their integrity, so to speak, from a molecular standpoint. And the whole process, it was actually described by my mentor, Dr. Ted Carrick. He used to refer to it as transneural degeneration. Transneural degeneration is kind of a severe process that happens like if you cut a nerve off, and then the nerve up here, which lost sensation from the hand, is going to degenerate. And they describe these changes.
Die.
Yeah, they're going to die. And so some of the changes that we're talking about are very subtle, but similar to kind of the transneural degeneration, Wallerian degeneration model. And another study going a little deeper, they showed that it's actually in fibromyalgia patients where there's these areas of decreased density. It's actually seeming to be a lack of water for the most part. So these nerve cells, if you want to think of them, think of a grape versus a raisin. So it's almost like your nerve cells are becoming like raisins. And possibly that's due to decreased protein in the intracellular areas of the neuron. So
the gray matter is decreased, but it's not inflamed.
but
Or it's not
they're
decreased because of
seeing,
inflammation.
They're not seeing inflammation though. They're seeing more
So you don't see that
correlation.
white matter. That's why they see the normal MRI, because they don't see that whiteness from the inflammation, but they but they see the shrinking.
Right.
I think it's important because everybody's on inflammation today.
Right.
Everybody's like,
That's true.
inflammation, decrease of water.
That was mainly what they found. And they saw another unifying feature to these MRI studies, and they're called voxel-based morphometry. If you want to look that up, that's what they're doing.
I'll look it up.
So it's just a voxel-based morphometry. So they can take an area of the brain and they can go further like a microscope would, and then they can see, okay, what is the density of this part of the brain? And they do see that the left cerebellum actually has increased density and increased receptors compared to the right cerebellum. And that's interesting for our model because different sides of the brain generally do different things. This goes back to the model of Roger Sperry. We've talked about it a little bit. Roger Sperry was a Nobel Prize winner back in the 60s, and he went around studying epilepsy patients. And back in the 60s, how they treated epilepsy was they would cut the brain down the center so that if you had a seizure over in the right hemisphere of your brain, it wouldn't spread to involve the left hemisphere. But he used this to study these patients and figure out, okay, do different sides of the brain do different things? And so he'd put a pen in their left hand and he would say, what is this? And they'd say, I have no idea. And he'd say, what is it used for? They'd say, it's used for writing. And then he would immediately do vice versa. And he'd say, what is this? And they'd say, it's a pen. What is it used for? They'd say, I don't know. So we delineated from there. If you ever hear about people saying, well, you're a left brain person, you're a right brain person, those are generalities from his research where he basically showed that mathematical functions, linear thinking, approach behaviors, positive emotions are largely from the left frontal lobe, for example, versus abstract thinking, abstract math, creativity, artistic ability. These are right hemisphere functions. And so we highlight the connection to left cerebellum because the left cerebellum connects to the right frontal lobe. And we see often in our fibromyalgia patients, when we do a neurological exam and we do a functional neurological exam too. So we're looking to see how your brain is functioning, how your eyes are moving. Are they moving just a little bit abnormal? Not enough abnormal to make me think that you had a stroke or you have a tumor, but just a little bit abnormal to say, hey, that's not right. And we see frequently in our fibro patients, not all the time, but frequently, that this right frontal lobe and this left cerebellum are overactive and the left frontal lobe is underactive. And so that was a very interesting piece of research to correlate with what we've been seeing for a very, very, very long period of time. Now, also, it's important, we kind of mentioned that the lower brainstem in fibromyalgia patients seems to have less density as well. And that's an area of the brain involved with shutting off pain. So most of our pain inhibitory systems, as they're termed, think of morphine. Morphine was discovered because our own brain produces it. And so your brain's ability to produce chemicals like morphine can be reduced in fibromyalgia patients because the brainstem actually has less density. And there is some thought that that connects to the insomnia of fibromyalgia patients. So if you have insomnia,
The whole brainstem?
basically the pontomedullary system, so not the morphine areas. It's really more the locus coeruleus and some of the serotonergic areas, endorphins and enkephalins, those being produced. But that being decreased in density is thought to connect to insomnia. So if you have insomnia, you can't sleep, you can't make the pain inhibitory chemicals, you can't shut off pain, and that's a vicious trap that a lot of fibromyalgia patients get stuck into.
Okay, so let's cut to the chase.
Cutting to the chase.
Like what, how does this, somebody watching this, how does this information play to them? What should they know? What symptoms does it cause? And what types of things are done to reverse it? Because I certainly am much better. I would assume that I am experiencing some of those improvements.
So to correct the brain, you have to have a body and brain approach. So we did with Dr. Rutherford, if you don't mind me exposing your HIPAA rights in terms of.
I don't think there's much that people don't know about me, at least people who come in here anyway.
Right. So for example, Dr. Rutherford has autoimmune thyroid disease. He has celiac disease, so he had gluten reactions. And he also had small fiber peripheral neuropathy. And so by treating him, with
my fibromyalgia.
Yeah, with his fibromyalgia, we've taken, I was illuminated under the heading of fibro.
Right.
So he's on a very restrictive diet. So he's eliminated gluten, yes, but many other foods that are inflammatory to his system. We've worked on his leaky gut syndrome. He's also had management strategies to calm down the immune attack on his thyroid. He's done neuropathy treatments where we've done electrical stimulation to correct in certain spots to correct his small fiber neuropathy. With all that, he's been feeling much better. He's doing brain exercises also, which have been, if you want to think of it, kind of like rebooting his central nervous system. Basically, these brain exercises are targeted at certain areas of the frontal lobe, which we have found not working well in him, in the parietal lobes.
Left cerebellum.
Left cerebellum, left frontal lobe. So we've been doing exercises for that, and all of a sudden his fibromyalgia is significantly improved. So that's kind of cutting to the chase. So you have to address all these potentialities, so to speak, all these balloons of things that are wrong in that fibromyalgia patient.
And I think more
important,
you
have to synchronize that with the brain rehab component. And then that's where we see phenomenal changes. And we treat a lot of fibromyalgia patients who, some just have autoimmune thyroid disease. Others just have small fiber peripheral neuropathy. Others have been exposed to horrible childhood trauma, the worst stories you could ever hear. They have autoimmune thyroid disease. They have IBS. And then they have small fiber peripheral neuropathy. So you just have to treat that individual for what they have going on.
Yeah, more importantly, my cognitive function is seriously way better. I still have some endurance, shall we say. I can't read more than like maybe an hour, 15 minutes, and then I have to take a break. I used to be able to read for hours and hours and hours before all this stuff happened. But I was going to say that more importantly, I can think, I can study, I can remember, I can do all those types of things. I don't have the brain fog I used to have. I'm not, and I think most importantly is no drugs. No drugs. And I wasn't taking any drugs to begin with because they terrified me and I didn't know what to do. And so I just thought I wanted to hang in there until I found some people who could help me. But yeah. So the cognitive function is, we're talking about fibromyalgia and decreased gray matter in the brain. So indeed, my cognitive function is, I'd say it's 90% better, 85, 90% better than it was.
And that's one of the most disabling symptoms for a lot of fibromyalgia patients is the brain fog. And the textbooks highlight that. Some people just say, I just can't think the way I used to. And that's the most frustrating aspect of the condition. Yes, the pain is horrible, but I just can't think. And
you're tired because of it.
Right.
It's contributing to your chronic fatigue along with your gut and your thyroid, but still.
Exactly.
Yeah.
So that's kind of getting to the nitty gritty of it. So basically these areas of the brain that have been shown to have decreased gray matter density are the emotional pain processing parts of the brain. So that's important to highlight. And so it's thought that with all the other components of fibromyalgia that we talked about, including small fiber neuropathy, that the brain gets overexcited, then it takes on decreased density. Then you're trapped kind of in this vicious cycle of physiologic dysfunction from thyroid to gut to abnormal brain processing patterns. And until you fix all these components and get the brain resynchronizing, that's where we've seen the major improvements in our fibromyalgia patient population. And so often it's, a lot of patients come in, they've done the paleo diet and they're not feeling any better. That's because it's only addressing one component of this whole system dysfunction. So that's fibromyalgia associations with decreased gray matter densities in the brain. And if you have questions, go to powerhealthtalk.com. Below today's broadcast on powerhealthtalk.com, you can find the research articles. You just search fibromyalgia, will come up. Did you have anything else you want to add?
No, we have a couple of 100 hours online on chronic pain, so you can just kind of go to that site. And if you have any questions about any other kind, you can just kind of type it in, and there's a presentation there of some sort on pretty much every type of chronic pain or chronic condition that there is. So you might help yourself to that too.
Perfect. So we'll be back next week with an interesting broadcast.